Medication Administration, Part 7, Iowa Lakes Community College, Introduction to Nursing Concepts, Martha Olson. As we finish this medication administration series, then we look at administering the medications. Before injecting, we always want to know the volume, how thick or viscous the medication is, what is the medication used for, and if we don't correctly administer the medication by injection, we can have poor outcomes or negative outcomes for the patient. If we have the inability to maintain the stability of the needle and syringe, it can cause pain, tissue damage, or needle breakage into the skin. If we inject too large of a volume of medication into the site that we select, it causes a lot of pain and can also damage the tissue in that local area. To minimize the patient discomfort, it talks about using a very sharp beveled needle in the smallest suitable length. Look at your site. Make sure you're using correct anatomical landmarks. Try to divert their attention. As a mother, I remember going to public health to get immunizations, and the nurse always had me hold the child with the legs between my legs and my arms holding the upper body. She would go into the vastus lateralis, and just before she would inject, she would give me the signal, and I would kind of blow a little puff of cold air into the child's face, and they would usually kind of react to that, and by then the nurse would have given the medication. So that was a trick I learned from the public health nurse that I have used in my career. We want to make sure we position the patient correctly so they're in as comfortable a position as possible, because that will allow them to be able to relax that muscle. And anytime you take a needle and put it into a relaxed muscle, they will have much less discomfort than when they are tight and they are nervous and you inject into the muscle because you're going through those tight fibers. Our subcutaneous medication is a 45 to 90 degree angle. Remember, the sub-Q should not have blood supply, so we do not need to aspirate. And the sub-Q is typically a very small volume that we give. Subcutaneous most often is our insulins. Other medications can be given subcutaneously, but we want to make sure that we are rotating the sites for that person. It provides medication delivery into that connective tissue. It's not as quick as the IM, but it is much quicker than the intradermal and the topical. As we start looking at sub-Q injections, then we want to find a nice place on the body that has a little bit of subcutaneous or fatty tissue for that person. On the left, then, you see the sites they recommend, and our photo to the right shows how the heparin is being administered into the abdomen by the nurse. That is a needle that once she takes that out, you can see that she's going to take her thumb and slide the needle guard up over the needle to keep herself from having a needle stick and being injured. The best sites for sub-Q injection include the outer posterior aspect of the arm, the abdomen from below the costal margins to the iliac crest, and then we have the anterior aspect of the thighs. The site most frequently recommended for heparin is the abdomen, and they don't really give a rationale for that, but when we administer heparin sub-Q, we rotate, and you will notice a lot of bruising to the abdomen. These are pictures from page 605. In looking at the angles of insertion, you have to use critical thinking as to where you want that medication to go and how much fat or muscle mass a person has. If you have somebody that's 500 or 600 pounds, you're going to be going into quite a bit of subcutaneous tissue, and you would definitely want a longer needle, or instead of it being an IM, it will actually wind up being a subcutaneous med administered. On page 605, then, it talks about the intradermal being a 15 degree, so it's just barely piercing that skin. You want the bevel up and you want to see a bleb as you administer that. All of you have had your Manteau test, and so you've probably had that in the inner aspect of the forearm as we look at intradermal for that purpose. Our intramuscular, again, faster absorption. There's risks with that, so we have to make sure that our injection site is where it needs to be in a very correct fashion. With the very obese, we can use a longer needle. For very thin people, we would want to scale that back to a 1/2 inch to a 1 inch. IM route is often used, like I said, in the clinic for vaccinations, for administering your antibiotics to children that need to get that in their system a little quicker than just going home with the oral antibiotics. The longer and heavier the gauge needle passes through, if you have to penetrate very deep tissue, or at times I've had to go through the clothes or the blue jeans on patients that are very uncooperative, we would definitely use a larger gauge needle so we don't break that off. The muscle is less sensitive to irritating and viscous medications. A normal, well-developed adult usually can tolerate 2 to 3 milliliters of medication in a larger muscle. Children, older adults, very thin, only 2 milliliters or less into each of the sites. As we look at intramuscular, we want to look at that muscle mass before injecting. Again, look for any bony prominences or landmarks. Think of the complications that we could have, and then again, try to get them to relax so it minimizes the discomfort afterwards. Repeated injections into the same muscle are very tender. If you've had an injection, sometimes after having a flu shot, your arm is a little stiff for the next couple of days. When selecting a site, look at an area that's free of infection. So if the stem of your question said something about, your patient has burns on the upper half of their body, you would definitely use, the vastus lateralis away from the area of injury. Or a patient that's had a left mastectomy, you would never want to give an intramuscular into that left arm simply because of the damage or potential injury to that. Each site has different advantages and disadvantages, and you just have to look at each situation and kind of determine the most appropriate landmark for that or site. Our landmarks for the ventrogluteal, I look at that and I see those two fingers spread apart, and you remember ventrogluteal as the V that the index and the middle finger form as you set up your landmarks for this. It involves the gluteus medius muscle. It's situated deep and safest for all adults, children, and infants, especially for medications that need a larger volume. The ventrogluteal site is recommended for 2 to 3 milliliters in an adult, and injuries such as fibrosis, nerve damage, tissue necrosis, muscle contraction, gangrene, and pain are all associated with common IM sites except the ventrogluteal. So that's why this is one of those that we typically use more often. To locate that, you want to position the patient supine or lateral, and for your test, you'll want to, in your head, be able to very clearly tell us what position a patient would be in. So put kind of a thought by that this patient is supine or lateral. They flex the knee and the hip to relax the muscle and also help with landmark location. Place the palm of your hand on the greater trochanter on the patient's hip with the wrist perpendicular to the femur. So you almost lay your elbow on their knee, run your arm, laying your arm perpendicular with their femur until the ball of your hand or the palm of your hand is on their greater trochanter. We use the right hand for the left hip and we use the left hand for the right hip. The thumb then points toward the groin, the index finger towards the iliac spine, and then that middle finger forming the V then is back to the iliac crest toward the buttock, and you go right then in that V-shaped triangle into the center of that for your injection. As we look at our vastus lateralis, you will want to give it into the ventrogluteal muscle. Then our vastus lateralis, as seen on page 607, is the muscle anterior, another injection site for adults and children. That muscle is very well thick and well developed, so it's an easy one to get to. A patient can be sitting in a chair in the clinic, pull their trousers down, be sitting in their underwear, so it kind of prevents a little bit of privacy issues when we use this one. It's the outer or lateral side of the thigh. That's why it's called the vastus lateralis. The site is often used for infants, toddlers, and children simply because as they start walking, it's a well-developed muscle that they have. Our next one is in the upper arm called the deltoid. Although it's easily accessible, it's not well developed in many adults, and our potential for injury to the brachial nerve is present because it has the axillary, radial, brachial, and ulnar nerves in that area. and they lie within that upper arm in that triceps area along the humerus. Use of this site for smaller medications like 1 milliliter or less is recommended, and we want to carefully assess the condition of that deltoid muscle. Think about the type of medication and the suitability of that medication. Use that site only for small volumes when giving immunizations or when other sites are inaccessible because of casts or dressings or traction. To locate the muscle, you want to fully expose the upper arm. So for that person in the clinic, many times it requires them to take off both shirts and sweater. You don't want to roll things up because it actually causes a tourniquet effect to that upper arm. Have the patient relax the arm. If they can bend at the elbow and kind of flex it a little bit. It helps if they are sitting instead of standing because they can relax a little better. And then we want to palpate the lower edge of that acromion process. It forms the base then of the triangle in the line midpoint of the lateral aspect of the upper arm. And we inject just below the center of that triangle, about 1 to 2 inches below the acromion process. You can also locate the site by placing 4 fingers across the deltoid muscle with the top finger along the acromion process. Our Z-track is done so that the medication is locked inside that muscle. We pull the overlying skin during the intramuscular injection. It moves the tissue further to the side, and when we release the needle, then we release the skin back and it locks that medication down into the muscle. It's recommended that when administering IM injections, the Z-track method is used to minimize local irritation. The medication B12 that's administered once a month for people that have pernicious anemia, that is a red colored medicine that always must be given Z-track, or you will notice red staining just below the skin on those people, and it's very difficult because that takes a long time to go away or be absorbed. When selecting your Z-track, then put the needle in on the syringe. We want to select your site. Place the ulnar side of your non-dominant hand just below the site and pull that skin about 1 to 1.5 inches laterally and downward. Hold the skin until you administer the injection. After preparing the site with that antiseptic swab, we inject deep into the muscle. Grasp the barrel of the syringe with your thumb and index finger. Administer the medication at a rate of 10 seconds per milliliter. If no blood return is noted on aspiration, and then we leave the needle in for 5 to 10 seconds to allow the medication to disperse evenly, and then remove the needle and release the skin at the same time. When we look at the intradermal, that's used again for allergy testing or tuberculosis testing. It's a skin test that requires us to be able to clearly see the injection site for changes. We use the 5 to 15 degree angle again with the bevel up, and we want that small bleb to form. We use a tuberculin or a very small syringe for this type of testing, and as we inject the medication, we look for the bleb. If a bleb does not appear, you're probably too deep and you need to withdraw a little bit, or if you are administering it and you are getting medication leaking out of where your injection site is, you'll want to go in just a little bit deeper to ensure that it is down into that area. We know that there are a lot of accidental needle sticks in the U.S. I have been and had one when we recap needles. So we do not want to ever recap a needle. Most of the needles now have a sharps, so you can just cover the needle either by laying that down and the guard comes up over it, or you push on the needle. The biggest thing is practice. Take a syringe and practice how you would use that needleless device before you actually go in and administer the medication to the patient. Our Needle Stick Safety and Prevention Act mandates the use of these special needle devices to reduce our needle stick injuries. If you have a needle stick injury, you will want to bleed the area. You will want to wash with hot soap and water, report it, and follow what your protocol is in that facility. This is the plastic needle then that comes, or the plastic guard that comes up over that. Here is our sharps disposal, and as we look at injections, we know that there are a lot of injections that have a lot of advantages, and we want to take advantage of that.